Good afternoon, everybody. I'll take you to the world of preterm babies from amidst the retinitis, taking a little bit of your time. I don't have the slides. Can I have a pointer, please? At the outset, I would like to thank AIOS, especially Dr. Lalit Verma, for having me here for this talk. I would be talking on management of retinopathy of prematurity. Let the little light shine. These are small little babies. It doesn't move. The slide does not move. ये चल नहीं रहा. Okay. Now it is important because India has highest number of preterm babies to the tune of 3.5 million, and preterms at risk of developing ROP would be around 2 lakh. And there are limited number of ophthalmologists who are involved in treating and screening for retinopathy of prematurity. Thus, India needs to scale up the services of screening and treatment of babies with at risk of retinopathy of prematurity. Now, RBSK has taken this up as one of the diseases where at-risk babies do need universal screening. So all preterm neonates with birth weight less than 2,000 grams and gestational age less than 34 weeks require screening. And this gestational age can increase to less than 36 weeks if risk factors for ROP are present. There are various risk factors for retinopathy of prematurity. This is just smooth, yeah. And in our setup, we found that double volume exchange transfusion is the most common independent risk factors for retinopathy of prematurity. We have to screen these babies in first 4 weeks of postnatal life. And in case your baby is smaller, is less than 28 weeks and less than 1200 grams, then we prepone the screening to 2 to 3 weeks of postnatal age. And it's a famous slogan by Dr. Subhadra Jalali, 30 din roshni ke, easy to remember. And after you screen, you must document this because of the medico-legal issues which are associated with it. We must know what is the extent of the disease, that is which zone it involves, and what is the severity of the disease. Zone comes from, like, zone 1 is twice the, with disc at the center, draw a circle, twice the distance between disc and macula is the radius of the circle. Whatever you see in zone 1 in a busy clinic, take it with a 28 diopter lens. If this is the field of view you are seeing and your disc is touching the rim of the field of view, whatever you are seeing is zone 1. And from the nasal ora serrata, the rim which is there beyond zone 1 is zone 2, and zone 3 is the temporal crescent which is left behind. And you must document what was the postnatal age of the baby and what was the dilatation status, and when does the baby come back again with the date of the baby. The severity of ROP depends on, you have to look at the vascular avascular junction. If it is just a small line, it is stage 1, stage 2 when the line gets volume, and stage 3 when there is extraretinal proliferation, neovascular proliferation, and stage 4 is when retina gets detached. And it's not complete detachment. Complete detachment is stage 5 ROP. And lower down there are just the images of fluorescein angiography, which tells you what exactly is happening to arteriovenous shunting, which is happening in stage 1, 2, and 3. This is another thing which we must all know, aggressive retinopathy of prematurity, because this is scarring disease. Here you have flat neovascularization, and the vascular loops are there in zone 1 or posterior zone 2. Here the disease does not grow to it just straight away progresses to stage 5. It does not go to stage 2, 3, where it doesn't give you time. You have to immediately act and treat these babies. And plus disease is actually dilatation and tortuosity of vessel. And with newer classification, it is very clear that it is not plus disease what it was, which is seen in the bottom picture on the right side. It was affecting all 4 quadrants. Now it is continuous spectrum. It could be normal, slightly more tortuosity, could be P+, or it could be more than that. And when do we treat these babies? So if the baby plus disease is very important, if you have plus disease in zone 1, all stages you need to treat. If you have stage 3 in zone 1, even without plus disease, you are going to treat. And in zone 2, if it is stage 2 and 3 with plus disease, that requires treatment. And now with tele-screening, which we are doing because of large number of babies which are having ROP, for this tele-screening, you have to identify what are the referral warranted ROPs. if in your picture you have plus disease, you have zone 1 disease, or you have stage 3 or worse disease, these are the babies who require referral. And then they have to be screened time and again till the time either the retina fully vascularizes or the baby goes on to develop the treatment requiring ROP. The treatment is you have to aim at decreasing the VEGF levels because that is the root cause of getting all this ROP. So what you have to do is either you ablate the avascular retina, which is the cause of all these VEGF levels, or you put anti-VEGF drugs. And then after laser treatment also, ETROP is the largest study which was done here. It shows that you have 15% risk of unfavorable outcomes. Anti-VEGF agents are gaining popularity. More and more people are trying to use it, but mind it, they are the treatment of choice for zone 1 disease. But the outcomes are suboptimal, and they can be used for other cases in case your laser has done and the outcome is suboptimal, or you have poor pupillary dilatation, or you have vitreous hemorrhage, vitreous haze, then you go ahead with treatment of anti-VEGF agent, which has to be with a safer strategy, which most of us know. You have to go along the visual axis of the patient, about 1 to 1.5 millimeter from the limbus. The timing is very important. You have to inject when the VEGF levels are high, that means 32 to 35 weeks of post-gestational age, not before it or not after it. And it has been seen that the single treatment success rates are higher with bevacizumab. However, ranibizumab is FDA approved right now for treatment. And it is seen that laser treatment matches bevacizumab in case you are giving for ROP, all stages. If you are giving for zone 1 ROP, yes, the bevacizumab definitely has advantage over laser treatment. There's a meta-analysis on pharmacotherapy of ROP. Now it makes it very clear, it is like pharmacotherapy is not a one-time treatment. We do get reactivation, and the major problem of vascular arrest is there, especially with retreatment. So you have to be careful while injecting anti-VEGF. We reserve it for zone 1 ROP. Otherwise, laser treatment is highly effective, and there's reduction in retreatment levels also. Now, we usually follow the amalgamation of two. Here you have this zone 1 ROP. The macula is hardly formed here. So you go ahead with anti-VEGF treatment. You let the vessels grow past the macula. And then you could add laser treatment to the peripheral avascular retina, which will be left behind. It just gives you some time till the vessels grow over the macula. Surgery in advanced ROP can be given for stage 4 or stage 5. It is good prognosis is there in stage 4 ROP. However, in stage 5, the prognosis is dismal. In ROP, doing little is a lot, so just cross all the traction bands. That is all you have to cut. Do not aim at removing the hyaloid in these cases. And the story does not end there. It's a long way. ROP babies are friends for life. So they could have other problems like myopia in long term, more incidence of cataract, more incidence of glaucoma. So once you see an ROP baby, lifetime you have to see that baby for other sequelae of ROP. Now this is the long-term follow-up. This is one of the first babies I treated. She came to me with stage 5 ROP. And one eye went into phthisis after buckling. The right eye has ambulatory vision. And this is, she proudly sends me MA political science. And I'm very happy to put this picture here because, yes, we are making a difference in the society. ROP screening requires lifelong association with the baby. It requires dedication, precision, perseverance, and patience. Follow-up preterm babies till the baby is out of danger of developing ROP. Risk of recurrence should be known, and long-term sequelae need lifelong follow-up. Let not an eye go blind. Let their light shine. So, this is small little babies. You have to save them, and everybody has to join hands. All retina people should screen these babies and refer to places where treatment is available. Thank you.
Thank you so much, ma'am. Thank you for such a comprehensive talk. Yes, a very important message. I think all retina specialists should learn this skill, and because if we can save these babies, it's probably much, much more important than so many other diseases. You are saving a lifetime of blindness over here, and this is a preventable blindness. So really, really a very important topic, and whomsoever can do it, I would also request, please learn this skill. little bit hesitation is there to see small babies, but if you can overcome it, it's a very good thing to do. Thank you so much, ma'am. Any questions for ma'am? Yeah, please.
Do you AC tap while giving anti-VEGFs? It's a very small. Yeah. Ma'am, what is the time difference between the anti-VEGF injection and the laser that you do in zone 1?
What we usually do is we let the vessels grow past the macula, let them cross the macular area, and probably like you would, the time where you are expecting the recurrence, you should see the baby then. So it is roughly around 4 months, you will expect the recurrence to be there. So in case the recurrence is there, normally we do fluorescein angiography also for these babies. That picks up any leakage, or then you go ahead with treatment of the.
Usually how long it takes for the vessel to regrow past the macular area?
No, it is like you would see the baby when, it depends when you've lasered first or when you've injected first. After that, you maintain on follow-up every 2 weekly.
2 weeks.
And you would see.
Dr. Devesh, you want to add on when to laser in ROP after anti-VEGF?
There are different approaches. So one would be people also laser just along with the anti-VEGF also at 1 week or 2 weeks and combine both the effects, but then it you're losing on the benefit of anti-VEGF therapy with that. You should allow the retina to grow beyond the macular area, or maybe zone 2 till the zone 2 posterior area is vascularized, and then maybe wait for the recurrence, or maybe at the high risk interval when it is about to come, maybe 6 to 8 weeks for ranibizumab and 10 to 12 weeks for Avastin, and then you can laser during that time.
So keep following up the baby, let it grow. If you have GA facility, let it grow even more, because the larger the baby, then under LA it won't be possible for you to do. Then you have to do under GA. If you don't have GA facility, then as soon as you feel you are comfortable and like the baby is not going to be uncomfortable doing laser, do it.
What is the interval for a repeat injection for you, sir? Like suppose you inject the baby and you feel after, like you follow it up weekly. So what is the interval for the repeat injection?
So your answer.
I would not go ahead with repeat injections, because we've done fluorescein angiography and we've seen, even Lepore has seen, that even after 4 years, the vessels, there's this halting of growth of vessels. So the vessel growth absolutely halts after repeated injections. So I usually stick to 1 injection. I don't know what doctor.
Rarely we go for second injection, mostly would like to laser it. Yes, Dr. Khosla, you want to add something? For a repeat injection.
And secondly, suppose there's a baby with stage 1 or 2, just stage 1 or 2, no plus. Till how many weeks of post-gestation you follow the baby?
I would follow till, for medical legal issues, you have to really follow till 45 weeks. Even if you see that vessels have reached zone 3, very unlikely that they are going to, recurrence is going to be there, or they are going to have treatable ROP. Still, on paper, the documentation has to be 45 weeks to 50 weeks, 1 follow-up has to be there.
Thank you.
Thank you so much. I think let's come back to information.